Welcome to When Worlds Collide 2012. As you can see, we've recruited an outstanding roster of speakers, including Catherine Lord, Clarence Sundram, and David Morrissey, all of whom have played a defining role in the field. I can also see from the many familiar faces that we have a really wide range of expertise and experience represented in the audience. So I'm very happy that you've all joined us for what I expect will be a really exciting day. First of all, it is my pleasure to introduce Tom James, Provost and Dean of the College and Professor of History and Education, who has graciously agreed to give a greeting on behalf of the college. Tom.
Good morning, and thank you, Linda. On behalf of President Susan Furman and our faculty and our board, I do welcome you here today. I think this is a really exciting time to be engaging in this conference and this discussion. Just one comment on the title. I was just talking with Catherine here, When Worlds Collide. There's a lot of disaster imagery in the world today, and the really fundamental thing about this work that we're engaged in is one of healing and of making whole and of using new knowledge to really advance human welfare. And that's really what Teachers College is all about. That's why we came into being in the late 19th century. And I think in recognition of the very great magnitude of human need that there is out there in the various fields that we represent. So from that perspective, we are delighted that this conference is taking place here. Even more delighted at the stellar speakers and their knowledge base and also their compassion and their commitment in their work. I hope you have a wonderful day engaged in this work, and thank you for being here at Teachers College for this occasion. Thank you.
I would like to brief you on the background of the Blackman Lecture Series. In 1999, the family of Leonard S. Blackman, a Teachers College emeritus professor and my longtime colleague, funded the Leonard and Frances Blackman Lecture Series on the occasion of Len's receipt of the prestigious TC Medal at graduation the year before. Since that time, we have all benefited greatly from this annual event, which not only brings world-class researchers to Teachers College, but also provides us with an annual opportunity for a reunion with members of the Blackman family, who are all beloved members of the TC community. This year, we happily have been joined by Leonard and Frances Blackman and their sons, Mark and Gary, and Gary's wife, Amy, and their daughter, Julie. So welcome, all of you. And this afternoon, we'll be treated to a performance of Silent Boy by Arts Power, Gary and Mark Blackman's touring theater production company. So we have a lot to look forward to today. Now it's my honor to introduce Catherine Lord, the 2012 Blackman Lecturer. And some of you will remember Dr. Lord as a highly regarded speaker at our 2009 Mind and Body and Autism Conference. Since that time, she has become part of the Teachers College community as an affiliated faculty member in the Department of Counseling and Clinical Psychology. After having been the longtime director of the University of Michigan's Autism and Communication Disorders Center, Dr. Lord has recently moved to the New York area. She has been named director of the new Center for Autism and the Developing Brain, which is affiliated with Columbia University Medical Center, New York Presbyterian Hospital, and Weill Cornell Medical Center. Dr. Lord is a licensed clinical psychologist with a PhD from Harvard and over 100 research publications. Among her many specialties are diagnosis, social and communication development, and intervention in autism spectrum disorders. Dr. Lord is known internationally for her role in the development of the Autism Diagnostic Observation Schedule, the ADOS, and the Autism Diagnostic Interview Revised, the ADER, considered the gold standard for autism diagnosis worldwide. Dr. Lord's work in her new position will involve continuation of her longitudinal studies, work on early diagnosis and regression in children with autism, and clinical evaluations and diagnoses of children and adults who may have autism. Dr. Lord has served as chair of the National Research Council's Committee on the Effectiveness of Early Childhood Interventions in Autism, as well as the chair of the DSM-5 Neurodevelopmental Disorders Committee. The title of her talk today is DSM-5 and Autism Spectrum Disorders. Dr. Lord.
It is great to be here. I was thinking that the title, When Worlds Collide, represents my life in a number of ways. One is being part of a center that is integrated across New York Presbyterian Hospital, Columbia, and Cornell. It's like we have colliding worlds every day in terms of what we're doing, and also in terms of talking about DSM-5, because although I don't think that the intentions of at least our committee, the Neurodevelopmental Disorders Committee, were all to create colliding worlds. This has generated a huge amount of controversy, and what I hope I can do today is clarify what it is that our committee was trying to do and what the questions are as we go forward. It's also a pleasure to give the Blackman Lecture and recognize that I am following in the footsteps of very esteemed people who have made major contributions to this field, and I really appreciate the opportunity to do this. What I'm going to do, and I should also say I'm actually not the chair of the DSM-5 committee. I'm actually a member, and somehow that got on something that was circulated, but I'm just one member. I also need to say I do get royalties from the diagnostic instruments. If the instruments are used in anything in which I'm involved, so our own clinic, our own research, Simons Foundation research, because I shepherded some of that research, the royalties are donated to Have Dreams, which is a wraparound organization that Margaret knows in Chicago. And this is the DSM-5 Committee on Neurodevelopmental Disorders. For those of you who don't know the politics of DSM-5, DSM-5 is a manual put out by the American Psychiatric Association periodically that defines diagnostic criteria for all mental health disorders. It's a bit unfortunate, I think, in the United States that what determines our billing codes, that is when we see somebody in a hospital and need to put in a code for how they should get, how this billing is getting reimbursed, it's determined by a private nonprofit organization, that, the American Psychiatric Association, because they're the ones who are most invested in doing this. In other countries, for example, in the UK and Germany, they have diagnostic codes that are generated by people that are appointed by government committees or something like the National Academy of Sciences. But in the United States, because APA has sort of stepped up to do this, this is what we have. The APA periodically creates new versions of these diagnostic codes. So the most recent version was in 1994, which was DSM-4. The APA, of which I am not a member, I'm not a psychiatrist, I actually have nothing to do with APA, except I ended up on this committee. But one of the controversies is that the APA makes huge amounts of money from selling these manuals. We don't get any money, we're not paid at all. And you can see from who is on this committee that they really wanted to diffuse who, partly they knew they would get slave labor from those of us who are really committed to autism. I mean, we were asked to be part of this. It's not an income generating thing at all for us. And this is the committee that was appointed. So there are child psychiatrists, but there also are people from lots of different disciplines. And this committee covers the whole realm of neurodevelopmental disorders, which actually includes learning disabilities, intellectual disabilities, communication disorders, and autism spectrum disorders. And we just found out that ADHD is going to be considered a neurodevelopmental disorder, but we aren't allowed to talk about ADHD because there's lots more people who have very vested interests in ADHD than us. We were selected by a committee of APA. I have no idea how. I just know we had to fill out many, many forms discussing conflicts of interest. And you've probably seen in the press, there have been many concerns in the past about relationships between members of APA committees and pharmaceutical companies. That's not a big issue for our committee. I mean, I think very few of us have anything to do with pharmaceutical companies. But I think you can see how political and emotionally charged this issue is. Now, there's a similar process going on to what's going on with DSM-4 on a much larger scale with what's called ICD-11, the International Classification of Diseases, which is done through the World Health Organization. It's for all diseases. So ICD-11 has codes for bunions and headaches and broken wrists, everything. And what's interesting is, though, one person writes the child mental health criteria. There's committees, but basically Michael Redder in London, a very well-known child psychiatrist, has written in the past and will write again the criteria for ICD-11. So I think the other thing to remember is, although we really want this to be scientific, and that's why the statistical was in the title of DSM-4 or 5. You ask, why on earth is it called a statistical manual? It's because the psychiatrist who started it wanted diagnosis not to be just random of, I know this person is neurotic, to move towards something more research-based. But the reality is this isn't research-based. It's politics. And what I'm going to hopefully do for you today is show you what we've tried to do to make this research more research-based and to make it more rational, and to help you understand how we got to the criteria that are proposed. So I'm going to talk about general issues in diagnosis a little bit. Then I'm going to try to go through one by one the major proposed changes from what were the DSM-4 criteria for autism or pervasive developmental disorders into the new criteria, which includes proposal of a new diagnosis, which is called social communication disorder. I'm going to talk about the idea of specifiers, which is something, again, that pertains to all of DSM-4, all mental health, not just autism. The idea of assessing overall impairment, which is also a major point of proposal, again, affecting all of DSM-5. Severity levels, again, part of the whole thing, and some general comments. I'm not going to talk about intellectual disabilities or communication disorders or learning difficulties just because it would take too long. But if you have questions, ask me. So what is autism, and why do we need a diagnosis of autism? And I wanted to just start with a short video of a little boy who has autism, and just illustrate a little bit about what are we thinking when we try to get a diagnosis. So this is a little boy who's in an early intervention program, just started, and we asked the mom to show us something that's difficult for her that she does with him. She learned about her son for a number of months, has been taking him to doctors and asking people what's wrong with him, and was getting the feedback that she just can't control him, and he's just kind of a bratty kid. And in fact, if you look at the video, it's not clear what's going on, except he's unhappy, right? And my point is that this is a place that, in fact, this little boy does have autism. You couldn't diagnose it from what we just saw, but he has autism and he's not very happy about having his hands washed. So two related but separate things. And the point is that sometimes we need a diagnosis to give us information, to give us access to services. In this case, with a diagnosis for this mom, came a home-based program to work with her, and better understanding of what was going awry with him, and also that this was not her fault. I just then want to show you a quick snippet of the same boy 6 months later in doing the same task, and just see the little things that his mother does differently.
Hey.
Now, I wanted you to see that, partly because, again, this is not diagnostic of autism, but he is a child who didn't understand a lot of what was being said to him, who at that point, when he was little, really wasn't talking at all, who really, because he turned away from people, there was constant fuss around getting him turned back. And so people were often in little, physical battles with him just to get him to look at them. And where it was very, very difficult to interact with him. And by doing little things, and this is a program that just worked with a mom on everyday activities. I mean, probably the most useful thing we did was get a step stool so he could see himself in the mirror. He's very cute, and he likes the mirror. And that started off, that made the hand washing a whole different experience than someone holding on to you and shoving you into the sink. In addition, just things like he really loved the hot water. And his mother was very concerned, and all of us would be, about him having the hot water. And there, we first tried to direct him to turning on the cold water. That was not going to happen. So we realized that if his mom held on to the cold water, she could manipulate what went with the hot water. And again, giving her and him this sense of give him some choices, but there are certain battles you're not going to win, and you should work around. Also slowing down what she's saying, pacing the communication, and focusing around as much as possible what he's doing. So you saw his little toothbrushing, where his mom, we really had taught the mom, if he heads for something and it's not something terrible, even though this is not the time to brush his teeth, it won't hurt him. And you talk about it and follow it if he goes for it. So my point here is that this is a case where actually a diagnosis helped. And although I realize these videos aren't diagnostic videos at all, it's a case where better understanding of what was going awry helped the mom understand what she could do and how she could do it. And it also just completely diffused this idea that she just had a bad kid and she was a bad mom, which is where this started. So I think that we also want to recognize that autism is a developmental disorder. Some of you have heard me say this millions of times, but I think it's just what is manifested as autism changes with development. So even in this boy, he's still autistic at age 2, but we see a different child in many ways than we did at 15 months. That's certainly true at age 30, or age 20, or age 10. So development changes autism. In addition, we really believe that development is affected by having autism. And this is one of the most important challenges for all of us as educators and interventionists, is that maybe we can modify how development is affected by autism. Many years ago, kids with autism had very little social interaction. They might elect to not interact with people, and people didn't push them or come up with appropriate ways to include them in social interaction, whether it's with a mom or a dad, or at a school, or in a preschool, or with their siblings. Today, we have many, many more opportunities, and I think we could do even a better job of figuring out how to engage kids with autism into the social world. And those opportunities, we think, really will affect the outcome of people with autism. I put this slide here just because this is a little girl who was identified under age 2. And then this is a group, an old picture of a social group I had, where when these kids started, we were meeting for social groups once a week. And literally, I had to write down exactly when we would do everything in this social group, because these kids had never even been in a group together where they were expected to interact. And I was constantly standing on a chair and crossing out 7:07, snack time, and writing 7:11 because snack was late. And somebody, if snack was late, would get upset because it said 7:07. But after being in this group for a while, kids got used to schedule changes. They got used to working together. And this was one of the most wonderful things that happened to us, which was we were supposed to have a barbecue in this summer. It rained. We waited and waited for it to stop raining, had many discussions of what on earth we could do. Finally, the students decided we could order pizza. They decided it. Someone ordered pizza. And here we are having pizza in the post-rain park. And people were okay. And that would not have happened, a few years ago when every kid that came in there had a different schedule that was supposed to be met. And if things didn't happen on schedule, heaven help us. So that's a place where I think we can affect how development affects autism. Now, in a diagnosis, what's a diagnosis supposed to do? Why do we even need a diagnosis? Well, ideally, diagnosis would tell us a cause or a pathophysiology. When you get diagnosed with strep throat, you know the bacteria that's caused your sore throat. But in autism, that is not the case. We know there's strong genetic components, but there are many, many genetic components. Many of those genetic abnormalities cause all kinds of things that aren't autism, so it's not specific. There's no direct route right now to autism in terms of cause. There's a few rare disorders like tuberous sclerosis and Fragile X, but even then, not everybody who has those disorders has autism. So we know there's neurobiology involved, but we don't know what. We know quite a lot about course and prognosis. We know that most people who get an autism diagnosis early do not completely grow out of it. But I think the thing there is things are changing every day. Hope, never stops, and more people are making progress. So we have an idea of what the prognosis is, but it's not limited. We know that's going to change. We have some ideas about appropriate treatments, but we really don't know which treatments work best for which kids. We know that behavioral approaches have documented success in improving cognitive skills when done over quite a long period of time, and we know we can teach specific skills. We know that there's something about engagement, social engagement, that makes a difference. But beyond that, we don't know what treatment works best for whom and when. And risk and associated difficulties, we know, again, quite a lot. We know that there's a much higher recurrence rate of autism in families that have a child with autism. If you have a child with autism and then you have another child, your chances of the second child having autism, if it's a boy, go up to maybe around 20%. So much higher than the general population. If a girl, it's more like 4%, so it's higher, but not as high. So that's an important fact for parents who have children with autism to know. Still, most siblings are fine, but it's a much higher risk. We know that more kids with autism have epilepsy than in the ordinary population. So we know that people need to be careful to watch out for signs of that. And I think there's a lot of concern right now about GI dysfunction and whether that is associated with autism. So right at this moment, and it's going to be over soon, we're at a very good point for diagnosis because DSM-4 criteria actually match up quite well with ICD-10 criteria, the World Health Organization criteria. When we go to DSM-5, it may not match as well with ICD-11. And actually, that isn't so much DSM-5 fault as just that they're not working together this time. We also know right now that if you get information from parents, you get a good history and description of a child, and you have a skilled clinician observing a child with autism, you can make quite reliable diagnoses that will be similar across countries, across regions, of the whole spectrum. With one or the other, if you just rely on observation and you don't talk to a parent or someone who knows the child well, or you just rely on information from a parent, a checklist, or even an interview, and don't have someone who's seen children with autism before, you will not get nearly as valid diagnoses. You'll be overly diagnosing many people who have other disorders, and you'll miss more subtle things. And one of the things, and I'll come back to this in a minute, is that we thought we knew that within a research program in several different places, a clinical best estimate diagnosis, that is clinicians taking this information and putting it all together to come up with a clinical diagnosis, added to the standardized information. Whatever you got from doing the parent interview and doing the observation, you put it together and it's even more stable. And that seemed to really hold true within different centers. So right now for DSM-4, autism is diagnosed by impairments in social deficits, speech and communication, and repetitive behaviors. All of this comes under pervasive developmental disorders. which was a term really coined initially, I think, or attributed to Lorna Wing, talking about the fact that autism affects every part of your life. We also have PDD-NOS, or pervasive developmental disorders not otherwise specified. Every diagnosis in DSM-4 has an NOS, and it just means not quite meeting criteria. Those are going to be eliminated in DSM-5 because many disorders, including autism, have more NOSs than just plain diagnoses. That is, more kids get PDD-NOS diagnoses than autism diagnoses. And the question is, what on earth is a diagnosis if most people don't have it? They've sort of got it. PDD-NOS is defined by having a social impairment and either a language problem or a repetitive behavior. And then there are various other combinations, for example, Asperger's syndrome, which is defined technically by not having intellectual disabilities, not having a language delay, but having a social impairment and some kind of circumscribed interest. Most people who are referred for autism do have a language delay, although they don't necessarily have it for life. They have it at 2. Not everyone, but most. Many, but not all, and the numbers are dropping all the time, of people who have autism spectrum disorders have intellectual disabilities. And the numbers really vary depending on how you determine your sample. It might be as low as 30%, it might be as high as 60%, depending on if you go through educational lists, you go through social services lists, depending on if you are in Finland or Germany or Japan or the United States. And then the reality is that most people with ASD or autism spectrum disorders have some of other problems. And I mean, the reality is probably all of us have some of these problems as well. So it's not just autism. But these things can make as big a difference as the autism. If you're not sleeping, that can upset your family and upset you as much as having autism. If you have GI problems and you're not eating or you're in pain, that can make a difference. So we're talking about both behaviors, ADHD, social anxiety, OCD, and then we're talking about a variety of different medical and behavioral issues that overlap very frequently with autism. Okay. So in the new diagnostic criteria, one of the things we wanted to do was leave room for consideration of those other factors, but to try to make people, try to make the system encourage people to be specific about how those other factors affected the lives of individuals. The other thing that's happened since 1994, and DSM-4 TR was proposed, is that we have many more referrals of younger kids. Many of us see kids who are 2 years old or younger. And the diagnostic criteria are not really written having examples of 2-year-olds. What is a friendship in a 2-year-old or a 15-month-old? And we define friendship typically as an independent reciprocal relationship that's initiated by the child and not based on context. Well, I don't know too many 15-month-olds who are calling up their friends saying, can we have a play date? Let's not tell our mothers. So we need criteria that address younger kids. There are also many more kids being referred who are older children, who might be 10 or 12-year-olds, who have had a host of different mental health diagnoses, ADHD, social anxiety, apraxia, all kinds of things, who may have ASD, who at 10, somebody is worried about their social skills. And many of these kids do not have intellectual disabilities, so they're kids with a lot of compensatory skills. So one question is, how do we better diagnose them? And the third group, which has increased greatly, are adults and adolescents who often have psychiatric comorbidities, but who may have ASD. So getting a call from a 24-year-old who's graduated from college, now can't find a job, has always had very clear preoccupations with somewhat unusual topics, has never had a lot of friends, always been socially awkward, and now is wondering if they have ASD and is depressed. So the depression is the key to the reason why they call, but in fact, there seem to be other factors. How do we decide if that person really has ASD or is depressed and is worried about all the things that other people worry about? I think we're also more conscious of special issues for girls and women. Because autism occurs more frequently in males than females, many of the criteria are written as if they're just written for boys or male men. And I think we're conscious that there are positive effects of early intervention. When we first started working on the diagnostic instruments, in the parent interview, we picked the period between 4 and 5 as the time when autism was easiest to diagnose, between 4 years, 4th birthday and 5th birthday. Because there, kids were old enough so that they were doing things, but they weren't so old that they were starting to get a lot better. Today, we see kids who may have been diagnosed at 2, started in early intervention at 2, and by the time they're 4, may have had 2.5 years of early intervention, and are actually looking a lot better than they were at 2. So we need to figure out how do we have criteria that address that. So all of these things make diagnosis more complicated. The other pressure we have is from the medical system, which really wants diagnoses to be faster. And that's something I have very mixed feelings about. Because I feel like, if you're getting a diagnosis of breast cancer, you don't want it in 2 minutes. You want someone to have a look at what's going on and to talk to you about it. But in autism, somehow there's this feeling if we can tack it into a pediatric visit and have it happen in 15 minutes, that would be great. And this is a life-changing event. On the other hand, in addition, if we're going to have faster diagnoses, we have to know who we're comparing kids to. So it comes back to that issue of autism being a developmental disorder. You need, if part of the autism is based on comparing this to somebody who has similar development, who are you comparing it to? If you're looking at a 2-year-old with autism, mostly you're comparing it to other 2-year-olds who have delayed language. If you're trying to figure out if a 24-year-old who is depressed has autism, you need to compare that person to other 24-year-olds who are depressed and then see, is there something else going on? And in order to make faster diagnoses, you have to know who that comparison group is. And that gets very, very complicated. So what our committee tried to do is take all of this into account. And the first thing, which I want to just say really firmly, because somehow there have been statements made to the press that were just not true. Our first goal was we were not trying to change who gets an ASD or autism spectrum diagnosis. Our goal of the committee was to say, all right, assuming, and that's what we said we're going to do, assuming that most people who have diagnoses within the autism spectrum need those diagnoses, and they appropriately describe something that truly is going on, how do we do a better job than the DSM-5 criteria at describing the individuals who should get those diagnoses? So the assumption really was we want to describe the same group of people, not make it smaller or bigger. Secondly, we really wanted to make the framework useful for all ages, developmental levels, genders, and degrees of severity. So in the current DSM-5 criteria, although we tried to do it, I was on that committee as well, there are many people that fall through the cracks. For example, there's a code on peer relations, which is not relevant to most little kids. So we wanted to be able to have broader principles that went across age and across developmental level, and then provide more open ways of applying examples. On the other hand, we're very aware that if you just look at the DSM-4 criteria, I don't know if any of you have seen, there's an article that was written in the LA Times a while ago where the reporter just took the DSM-4 criteria, posted it on the LA Times webpage, and asked people to say, does this apply to you? And I mean, they had horrendous numbers, like more than 50% of the world thought they met DSM-4 criteria for PDD-NOS. Because do you have moments when you avoid eye contact? Well, all of us have moments when we avoid eye contact. Do you have moments when you don't want to be around other people? Well, most of us have sometimes, Do you have moments when you're rude? Do you have times when you can't think of what to say? So you can get, if you broaden those criteria, you can get anybody in there. Now, that's not the intention of DSM-4, but that's the problem with using a simple checklist. And so one of the things we were trying to do with the criteria was, again, identify principles that would be constant across individuals who have ASD or autism spectrum disorder. The other issue in DSM-4 was because it's a Chinese menu approach. You choose 2 from here, 1 from here, 1 from here. As Fred Volkmar at Yale said, there are like 278 different ways of having ASD. We didn't think that was actually good. What we wanted was principles that were constant, but then possible different examples depending on your developmental level, language level, and age. So that we wanted to be able to say there are some things that everybody with ASD share across these principles. They won't be the same behavior because 12-year-old boys don't do the same thing as 30-year-old women who don't do the same thing as 18-month-olds. But that the principle should be the same. And in that respect, the criteria for DSM-5 are narrower. I mean, that is a fair concern because we've tried to have these standard principles instead of you can do this but not this and this but not this and end up with people who don't look like each other at all. We also really wanted to have ways of separating behaviors, separating strengths, which we think are really, really important, and other specific difficulties from ASD. So we wanted to pull intellectual impairment out of ASD and say there are people who have autism spectrum disorders who have an intellectual disability, and there are people who have autism spectrum disorders who are far brighter than any of us. And that should be clear and stated explicitly, rather than have that as sort of a subtext when you use terms like Aspergers. We also wanted to pull out the genetics from ASD, because the reality is people are finding new genetic abnormalities every day, and often they're not specific to ASD. So we wanted to have a way of saying you meet criteria for autism and you have a deletion on your, the little arm of your 16th chromosome. So you have the autism and you have that deletion. And someday maybe we'll figure out what that deletion does. You can have autism and you can have Fragile X. So you have both of those, or you just have Fragile X and you don't have autism at all. And part of this is to address the concern of parents of kids who have Fragile X or Rett syndrome, which were separate categories in DSM-4, because sometimes they couldn't get services for autism, even if their child had autism. So the idea is just to say, look, autism is a behavioral diagnosis. It's associated with abnormalities in brain function. We know that there's some neurobiological origins, but we don't have a biomarker for it. So let's just say we're describing behavior, and then we have other descriptions, for example, of genetics, or of epilepsy, or of GI. So those are important, but they're separate. So the first proposal was that we have one spectrum of autistic disorders that's called autism spectrum disorder. And again, recognizing that this is defined purely by behavior. The logic here was that although individuals clearly use the terms PDD, NOS, Asperger's, autism, childhood degenerative disorder to mean different things. The reality is that they are so idiosyncratic, how people use those terms, that it causes more problems than it offers value. The other concern, as I said before, is it often underrepresents important aspects, for example, intellectual strengths or disabilities that get lost in a term, that we feel like it's more important to say this is a person who has ASD but who has real intellectual strengths, that is more helpful than saying this is a person who has Asperger's. Numerous studies have shown that when you compare kids or adults who have high functioning autism to individuals with Asperger's, and you match on verbal fluency, how well people can talk, there are no consistent differences unless you've specifically recruited for a group of people. If I'm looking for people who have motor problems, and I call them Asperger's, and people who don't have more motor problems, high-functioning autism, I'm going to find that the people with Asperger's have more motor problems than the people with high-functioning autism. But if I just collect individuals with these diagnoses, it turns out that the differences are completely circular. The other concern is access to services, that people with Asperger's in some states cannot get services. You can't get, in California, you cannot get early intervention for a child with Asperger's syndrome. If you're going to Social Security or trying to get Social Security in some states, you cannot get Social Security for people who have Asperger's syndrome. So many of us have been in the very awful situation of having kids that we diagnosed with Asperger's syndrome who then need services and having to say, all right, I take it back, this is autism. And then I want to just show you one piece of data that I think really influenced me in terms of the distinctions between the different categories. And this is from the Simon Simplex study, which is actually a genetic study where we saw, actually it's now up to 2,700 families. So 2,700 families that had a child with some form of ASD, a typical child, and then this is really focused on, my job was to describe the behavior of the children and the families. And then the geneticists have taken over and are doing general kinds of genomics. This was a study that took place in 12 sites in the US and Canada, and we were just obsessive about reliability of diagnosis. So all of the sites used the same instruments, and we did repeated reliability testing of the interviews that people used with the families and the observations that the clinicians made with the kids. Sorry, this is just the sites around the country, including Columbia. We then, although we were absolutely obsessive about the diagnostic instruments used and about the reliability of the diagnosis, and unfortunately you can't see the numbers because they're in yellow, I'm sorry. This is a paper that's published actually in the Archives of General Psychiatry, so you can look it up and see the numbers. At the end of the diagnostic assessment, we let the senior clinician of each site make a clinical diagnosis. And we asked them just to use whatever they would use in their clinical practice, these are all university centers, in terms of autism, PDD-NOS, Asperger's syndrome. And what is amazing is that these clinical diagnoses are all over the place. Now let me see if, yeah. So let me show you something first. This is just an example of the standardized instrument. This is a parent interview. The RRB is repetitive behaviors. So all of the kids in this study had the same interview. We worked with the interviewers to make sure they were doing this in the same way. And these are the distributions. Each line is a different site. You know, could be Columbia, Harvard, Yale, UCLA, University of Washington, Michigan. And what we found was this is a big distribution. So this means a lot of repetitive behaviors. So there's a lot of kids in here. This means very few, and in the middle. And on the whole, the distributions of these standard diagnostic instruments were very similar across sites. So there's a lot of variability between kids at each site. There are kids with lots of repetitive behaviors at University of Washington and very few. Lots of kids at Michigan with lots and very few. But across the sites, the distributions were very similar. But when we asked the clinicians to make the diagnoses, we had all kinds of variability. We had one site that called every single child, all 235, autistic. They had no Asperger's, no PDD-NOS. We had another place that called more than half, or about half the kids PDD-NOS, with a little bit of with autism and Asperger's. We had another site that had pretty much 2 equal groups of Asperger's and PDD-NOS with some autism. And we had pretty much everything in between. The point is, the distributions of the behaviors of the kids were the same across the sites. But the distribution of the clinical diagnoses would have implied that they're seeing radically different kids. Does that make sense? And they weren't. So then we did an analysis where we tried to figure out what were the factors that sites were using to determine what diagnosis they gave the kids. This is just from the first third. We've done this now in the paper. You'll see the whole thing. But we started up here, and the first thing, if we take all the data and try to figure out what factors predict what diagnosis does the kid get. So blue is autism, red is PDD, green is Asperger's. The first factor was the ADAS score, the observation score. So kids who got high scores, which means more severe, more severe, mostly got autism diagnoses. But this second factor was not anything related to the kid. It was where they were seen. So if you wanted to know, did a child get a diagnosis of autism or PDD or Asperger's, you should ask, what is their ADAS score? And then you should ask, who saw you? Not any characteristic of the child, but just where they were seen. And this is not good. I mean, this is not the way to do diagnosis. The other thing that is actually even more scary is that the different sites used different information. It wasn't just the different sites. They used different information to determine these scores. So some sites were very interested. These are all mild kids, so you can see there's a lot more variability with the kids who are mild, which makes sense. Some sites looked at how many repetitive behaviors kids had. And if they had a lot, they got PDD-NOS or autism. If they had a few, they got Asperger's. Some sites looked at Vineland scores and looked at daily living. If the child was very functional, they got Asperger's. If not so functional, PDD-NOS. Some used age. So if the child was over 8, they got one diagnosis, and under 8, or just like 7.5, another diagnosis. Some used irritability. And when we looked at this more closely, we had sites who used IQ, for example. Some sites, actually, I mean, this is really depressing, but in the Midwest, the distinction between Asperger's and autism was often between 70 and about 85. We have an Ivy League effect, which was around 113 to get an Asperger diagnosis in the Ivy League schools. So you have parents in the Midwest who are being told, wow, your child has an IQ of 72, he's brilliant, this is Asperger's. And you have the same parent going to somewhere in the East Coast and being told this isn't Asperger's. Asperger's kids are much smarter. So these are the individual decision trees for the different sites. And you can see that they have you can't see what variables I know, but they have different distributions of these diagnoses and different factors that contributed. We also had a social class effect. So basically, upper middle class, well-educated mothers were much more likely to have kids with Asperger syndrome than anybody else, even controlling the characteristics of the kids. So the point is, this is not good. And this is not how we want medicine to occur. we also get people wrapped in circles who are saying, my child, actually, just since I've been in New York, I've seen 4 families who said, my child has PDD-NOS. I was told by the developmental pediatrician when he was 2 years old, he has PDD-NOS, not autism. And here is a 4.5-year-old who's not speaking, who has autism as much as anyone in the world has autism. And the family has built their whole conception of the child around this is not autism. So the point here is just that we need to do a better job here. Now, I think we need to be careful because we're not saying that people who had diagnoses of Asperger's or PDD-NOS should lose services. We're saying the opposite. We're saying this is all one spectrum, and that if you had one of these diagnoses, it is part of ASD. We are not excluding these people. We're including these people. We're also aware that Asperger's has much less stigmatization, and many people prefer to use the term Asperger's. And I think if people prefer to use that term, especially people talking about themselves, that's appropriate. Nobody is trying to stop that. It's just not a medical, scientifically valid distinction. It's a definition, and it can be a definition for whatever people want it to be, but it's not a formal diagnosis. I think the other concern was that by lobbing everybody in together in autism spectrum, we would minimize the huge differences between individuals in skill levels. And the point here is we're really trying to actually fight that by having specific acknowledgement of intellectual skills and language skills rather than having that subsumed within a diagnosis. So rather than having Asperger's or PDD-NOS, which sometimes means smarter, sometimes means less irritable, sometimes means you lived in the Midwest, having a diagnosis of autism spectrum and then intelligence and language level and strengths in other ways. Another change is the number of domains. Remember that we started with social and communication as separate domains. The problem there is that if you look at the criteria, for example, conversation, is a conversation social or is it language? Nonverbal communication, eye contact, is that social or is it communication? It ends up pretty random where those behaviors go. So the idea of the committee was to push the social aspects of communication into a social communication category and put the repetitive aspects of communication, so echolalia, verbal rituals, stereotyped speech, into restricted and repetitive interests. And then pull out language level and say that is a separate skill that needs to be acknowledged on its own. It's so important that you should always know the language level of a person that you're diagnosing before you make a diagnosis and not hide it within these subgroups. Now, there have been studies, questionnaire studies of typical populations that do find these separate groups. But we think that part of that is that what they're getting here is just how much people talk and how well people talk, which is a different issue than what we're talking about in ASD. And within ASD, social domains and communication domains are very highly correlated, often over 0.8. So it seemed to be clearer to just say, look, we're talking about something together. Another new proposal, though, and this is what I was referring to at the very beginning, is that there are 3 principles that define ASD, and we're proposing, and again, this is something that might be changed after all the new data, but is that there are 3 principles, and these are on different levels. The first level really has to do with nonverbal communication, interacting with verbal skills if a person speaks. So these are deficits in eye contact, facial expression, gestures, how you hold your body. And in a fluent, verbally articulate adult, it may be not that they don't look at anybody, but that they're not quite they don't quite get the timing of when they look at someone when they're talking. They might look at you too much when they're talking and not enough when you're talking, which is actually very subtle things, but that do affect what it feels like to talk to a person with ASD. The second level, so that's very basic behaviors. The second level has to do with social emotional reciprocity. And this is defined by contexts in which you're interacting with someone else. So this would be offering somebody comfort if they were hurt, or sharing something, or enjoying doing something, or joint attention, pulling someone into your activity. So on an immediate level, interacting with someone else. And the third criteria, or principle, has to do with developing and maintaining relationships, and then also, and actually I just ran out of space here, adjusting your behavior to general contexts. So this would include an adult with ASD who has a group of friends, but who has never had an intimate relationship. It would also include a toddler who is very attached to his mother, recognizes his father, and doesn't notice his grandparents even though he sees them once a week. Or a toddler who actually is not very interested in his siblings. Yet, that is something that almost always changes. So it doesn't have to be friendships, it doesn't have to be intimate, relationships or spouses. And it can also be adjusting your behavior to context. And what we're thinking about here is that, for example, we work with young adults with ASD in our center. And one of the hardest things sometimes is them understanding who is a supervisor, who is a mentor, who is a friend. Who can I say what to in relationship to a job? And this idea that there is someone in this job who really can tell me what to do, even though they are the same age as me. And there's someone else who can't, and who I can have coffee with and be totally free with in terms of what I say. Now, I think where things have gotten very problematic in terms of the recent studies that have come out is that the idea is that each of these principles can be exemplified in hundreds of ways, and that what's specified in DSM-5 are just examples of how you might want to exemplify these different principles, but that ultimately it's up to the clinician to say, I'm looking at an 18-month-old here who doesn't have any brothers and sisters, who spends most of his time with his mother or with his nanny. So what would be a reasonable example of this principle? I need to think of it. So, or I'm talking about a really brilliant adult who has gotten through a PhD in physics and who has clearly handled all kinds of social expectations, but is really struggling. And again, what is the principle? Is there an example in this principle? So I think what's hard is when people take existing data sets, even registries, like there's a Finnish study that some of you might have seen, or large data sets. We have one where we have 200 question interviews. We may not have asked the questions that a clinical way to address developmental, age, gender, cultural differences that might be appropriate. Another shift is that we have added some repetitive behaviors and reorganized these. And I have to say, this is the work of a committee. This is not, there are some empirical justifications for this, and some just who shouted the loudest and longest. So this is our attempt, a group of 15 people, to get something we could agree with. I won't tell you what I don't agree with, but so we came up with 4 areas of repetitive behavior. We have added a number of things to DSM-4. The most obvious one is hypo and hyper reactions to what we're calling sensory input. This is completely new. It is not in DSM-4. It's been things people have been talking about for years and years and years, but it wasn't there. we have also added in resistance to change, which is not in DSM-4. So we've added it into this group of ritualized behaviors. Okay. And repetitive language, stereotyped or repetitive behavior, language is now part of repetitive behaviors. Okay. So there are many more ways of having a repetitive behavior than there were before. Now, the reality is most of us in this room will have one of these things. You know, the other change is this includes history. So you don't have to have all of these now. This, unlike the social, where a person does have to show the problems now, but can show them in many different ways. For repetitive behaviors, this can be done by history. And it's partly that we know often assessments are short. I might not happen to see somebody do some of these things. And also people with autism do grow out of some of these behaviors. So you don't have to have them now. It can be at any point in your life. But you do have to have two of them. And that's because the typical population has one of them, if you really stretch it. Again, the other problem with using existing data, for example, the DSM-4 checklist, is this is not on that checklist, nor is this in that way. So to say that people don't meet criteria on the DSM-4 checklist that we would need for DSM-5 is just because the question wasn't asked. Now, I think my point is, actually, I'm going to just show you another one. This is a wonderful mom, and we'd asked her, when is your child happiest? And this was it, throwing plastic plates at the coffee table. This is another repetitive behavior, very classic. Now, I mean, he has done incredibly well, and actually his strong interest, which is digital audio, has paid off completely. I mean, he went, actually this was a few years ago, he went to a 2-year college, majored in digital audio. He was the most responsible person who was ever in that digital audio program. And actually he's working in digital audio. But when I first asked for a clip of him to show somebody who had done so well, my research assistants gave me 4 different clips, and I looked at them and I was like, why are you giving me the same clip over and over? And it's just because he could get digital audio into any conversation. You'd ask him, what makes you happy? Digital audio. Do you have any friends? Yeah, I really like the guys in digital audio. No, when is life tough? When I can't work on digital audio. So, but my point is, for him, this was a really good interest. I mean, he found something he could do. It was something that was age appropriate, and it's something that he loves to do. And we all, I'm sure I have moments of like this, just talking about autism. It's like, please talk about something else. But I think the point is that these restricted repetitive behaviors are a huge range of things. And I would bet for DSM-6 or DSM-10 or whatever, we won't have this category. We'll have some better sense of what on earth is going on here because we're covering such a range of things. But I believe, and there are certainly people who disagree with me, that there's something really different about having these kinds of repetitive behaviors and a social deficit that you don't get in other disorders. You may get just the repetitive behavior. I don't think you really get the social deficits in very many cases without the repetitive behavior. And one of the things I've just been on a campaign to get the scientists to acknowledge is we need to know, why do these things happen together? It's not just random, and I don't think it's just 2 hits of 2 random different disabilities that come together, because there's all sorts of evidence that they're not that separable. So what on earth does that mean? Sorry, I'm digressing. Anyway, one of the concerns was that with the new criteria, you do have to have a repetitive behavior. And our analyses of a whole lot of big data sets with lots of information have suggested that there are very few people who get called PDD who really don't have repetitive behaviors. But the concern was, if there are people who have social deficits without a repetitive component, what happens to them? So our committee has proposed a new diagnosis which falls as a communication disorder. So it goes along with receptive and expressive language and various kinds of language problems, but it is called social communication disorder. I honestly don't know if this will work at all. I don't know, and I don't think any of us know. But the idea is that if you really don't have repetitive behaviors, then your treatment is going to be socially and communicatively focused, and that is where this belongs. What's been said very clearly, but I don't know whether people will take it seriously, is that you can't make this diagnosis without ruling out ASD first. And I don't know if that will happen. I mean, it may become the new PDD-NOS because people will think it's less stigmatizing, but probably people won't get the services that they get for an ASD. I've already talked about this, but I think something that does just not get taken seriously, which I think is really, really important, is the idea that we are not ruling out genetics or ruling out other kinds of factors. We're actually trying to have a better way of taking them into account with diagnoses. So you'd have ASD, and then you could have an unlimited list of other kinds of disorders or problems. We also are taking out, there's no longer a particular age of onset, that you have to have ASD symptoms by age 3 or 2.5. But what we've said is early childhood. There needs to be some problems evident in early childhood, although they may not be manifest or taken seriously until social demands increase. So the idea here is for a child who is bright, who is socially quirky, and who is in a very freewheeling preschool, for example, and doesn't have, and whose parents are comfortable with that, who hits a really tough kindergarten teacher, and all of a sudden people are saying, oh my gosh, we have onset of Aspergers or something, to back up and look and say, look, this child has always had these issues. It's just that they weren't interfering with his life in the context before. So there's age of perceived onset, and then there's actually also recognition of, is there a gradual accumulation of things that provide evidence for autism? Is there a marked change, such in kids who have these very dramatic regressions, something that doesn't happen that often, but certainly can happen? Or is there a plateauing and then perhaps some language loss? Part of the whole DSM-5, so not at our committee at all, just everybody, is that they want the psychiatrists or people making diagnoses to attend to general characteristics or dimensions. So we've already talked about these things. So we would try to get people to pay attention to not just does this child have autism, but just are they sleeping? I've just put, are they eating? What is their activity level? What is their adaptive functioning? Is this child toilet trained? And then we've been required by DSM-5 for every diagnosis to have severity dimensions. Our group was actually quite uncomfortable with this because we couldn't figure out how to separate severity from impairment. The medical issue is that I could actually have a severe heart condition but not know about it at all, so it doesn't impair me. Or I could have a broken ankle and not know about it, or be hopping around on it, and where someone else with the same broken ankle might be, in a cast and refusing to move. So they're trying to make the distinction between how impaired I am from how severe my condition is. But when you get to autism, I don't think you can do it. And I think this is true for a number of other mental health issues. We were also very concerned, and again, this speaks to some of the controversy, which I think just got it backwards, that we did not want people who were doing well because they had a lot of support to lose that support. And that really gets into a vicious cycle. So the way we've defined severity is by how much support you need to do well. And the idea here is that if you have somebody who has got a great life, I mean, one of the young men I know from my research has an IQ of about 20, has severe autism, but lives with his grandparents, who are the world's most wonderful people, is in a great program in school, and works in a bakery that happens to be 2 doors down from where he lives, and he is doing incredibly well. But if he didn't have that job and those grandparents, he would be a different person. So he would go here because he needs very substantial support. And the logic here is we don't want people taking away that support because someone has done well. I added, and I should be really clear here, these two rows are mine, not the committee's. And just the idea that there are people with subclinical symptoms, and that there are people who may today say they have Asperger's, but don't have an impairment. If that's the case, they don't fall in here. I mean, DSM-5 is really for people that need help. If you're just describing aspects of your personality, you could still use the term Asperger's, but you don't get into here because this is a diagnosis for someone who's seeking help or who needs help. And then there's also normal variation. So we all have moments that overlap with ASD all the time. But that doesn't get you a diagnosis either. Okay. I think what I'll do is I'm going to just wrap up and just show you this, which is a wonderful video from District 75.
I was asking Randy,
and these are 3 young men with autism who are talking about what it's like to have autism. That what they're talking about is they've been in a social skills program that was created by Michelle Dunn. Some of you know her. And they're talking about what it's like to have autism. And they were saying that they at first didn't know what it was, but then they got used to it. And then one of the guys says, well, don't be cocky about it, at which point they all get the giggles and discuss whether cocky is an appropriate word. And then they decided that arrogant was a better word than cocky. And then they talk about, well, it's good to be arrogant sometimes because they've done so well that they're really proud of themselves. But then one of the other guys says, well, but you shouldn't get too arrogant or then you're cocky. So it's just a really nice discussion by 3 young men who have clearly thought through these ideas and also really gained a lot from this social program. Where they're really, you can see them just making an effort to listen to each other and respond to what the other ones are saying. And again, that's something that we all have moments of like, oh my God, I better listen to what this person is saying, and that's what they're doing. I feel like autism is more than the sum of its parts, and that the reality is the diagnosis is just the first step. I mean, basically, a diagnosis should be a ticket to services, not all the same services, but recognition that this is somebody who needs help. It should give you information beyond what you knew about the individual already. So you should be able to say, based on this diagnosis, I can use sources of information and ideas that I've used with other kids or other families that had similar issues. Because autism is so multifaceted, that has to be a multifaceted diagnosis. And the ASD label is just a start. I think recognizing that it's broad, that it represents at least 2 different dimensions, and within that, different principles, but there are many different ways to get to the same point. And that strengths are as important as weaknesses. So being able to say, this is a person who is very articulate, and has autism, or is very bright, or who has real strengths in motor skills or visual spatial skills, is as important as saying these are the deficits. I think that there are lingering questions. We don't know for sure what the consequences of the new diagnostic criteria are. There is no intention that they're going to drop or cut the number of people with ASD. What we do think they will do is that if you're just going through questionnaires and picking out items, it should cut the number of people who end up with categories of ASD from these questionnaires. But in terms of actual diagnoses by a clinician, putting together information about history and seeing the person, We don't think this will change, and we hope it will actually do a better job with younger kids, adults, girls, and people from other cultures. Because you can say, in this culture, eye contact in this context is not appropriate, but in this context is. Or here is a behavior that would really be considered socially odd, that might not be odd for, upper middle class, white, 5 to 8-year-old boys, which is what DSM-5 was written for. I think it's also important to remember that the diagnostic criteria are not the same thing as the actual diagnosis. I don't think now most clinicians misdiagnose kids. Even though the DSM-4 criteria are very broad, I think most clinicians say, well, when you meet a child, for example, who's very shy, you think, well, they could meet eye contact criteria, but they're very shy. So the shyness accounts for the behavior. And so you do rule out people who would meet them if you just took them literally. So I don't think I think we are trying to provide criteria that help clinicians better making diagnoses. And I think we really, really, really want to remember that ASD is not an endpoint. ASD is a description of certain set of difficulties that come with other strengths and weaknesses, and we always have to be aware of that. And I just wanted to end with this picture, because this little guy was our first participant in a toddler study whose parents then just went out and got the world to come see us, but who has done incredibly well with autism, with lots of repetitive behaviors, with an initial language delay, but with quite high intelligence. And he's a lot of things besides those ASD criteria, including a little baseball player. So let me just end here, and thank you very much, and I'm happy to take questions if we have time.
But one thing that strikes me is this: there seems to be a serious flaw in just the whole problem is with measurement error. And that slide you just showed a second ago with the people on the committee, are any of them even psychometricians?
Well, a number of us have lots of training in psychometrics, but psychometrics is not figure in very much to DSM-5. I mean, I think you are right.
That's disgusting when the S in DSM is supposed to be statistical.
Well, you're right.
And even more so, though, it seems to be, you said earlier that we want to make sure the criteria make sure to describe ASD and not describe people that don't have ASD. Basically, you're worried about false positives in making a diagnosis.
That's
the problem, though, is if you're guarding against false positives, you do it at the expense of the false negatives. This is just a simple thing, type 1 error, type 2 error. And I'd say it's a far more serious issue is the false negatives. That's a person who actually does have the condition, does not get the diagnosis, therefore they get no services, they get no help, they get no treatment. In fact, there's been studies in Pennsylvania, Norristown, about epidemiologists finding people in institutions and like the 50s and 60s, like basically a whole generation of people who've been ignored and only just recently realized that they have autism. And if anything, they found that's the same rate in the older generation as in the current one. So the so-called autism epidemic is baloney. The rate has not changed.
Right. Well, first of all, I agree with you. I think the rate hasn't changed. I think that we're doing better and better identifying people, but there's still people out there who haven't been identified. So I think you're right. I think if we do this well, the prevalence rates are going to keep going up because we're going to identify people that aren't identified yet. I also think you're right that sensitivity is a higher priority than specificity. But I think what we do have to be concerned with is the specificity can't be terrible. I mean, I could have a completely sensitive instrument by saying, everybody who's ever had a problem has ASD, and I will identify everybody, but then I will also identify 99% of the people who say they have ASD don't, and we can't do that. So I think you're right. I think everybody is prioritizing sensitivity over specificity. You are absolutely right. But I think where sometimes we have to be careful is we need to know what the specificity is. Anyway, good points.
Hi, thank you so much.
Or wave your hand so I can see where you are. Okay, gotcha.
I have 2 questions. One, if you could maybe speak a little bit more about the social communication disorder and whether or not I'm assuming there's not a sensory component to that. And you referred to maybe this potentially being a similar problem to PDD and OS, and I'm wondering if caregivers are also going to be thinking that their child, does not have quote-unquote autism. So if you could speak a little bit about that. And my second question is slightly off topic, but I was intrigued by the conversation of the 3 young adults. What do you think about the affected individual themselves being in on the diagnosis and how to approach that, and maybe exactly what their diagnosis is?
Okay. So for the first question, there isn't a sensory component to social communication disorder. So I think the idea is that generally speaking, if somebody had a sensory issue, the chances are very high they also have some other kind of repetitive behavior, and that would pull them into ASD. So I think that we don't know how that social communication disorder diagnosis will be used. We really have tried to say, first you have to rule out autism. But whether people will do that, I don't know. We just don't know. And we can't prevent parents from choosing less stigmatizing disorders or from going to practitioners who use less stigmatizing categories. But I think that is not the intention. I mean, the intention to say is we really don't want to stigmatize ASD. We need to say, look, this is a real thing, but it's just, it's like a learning disability. It's one of many ways that things are not quite right. All of us have got something, and ASD is one of those. It shouldn't be particularly stigmatized, but we don't know. I think that for the young men, I think it is really important, when somebody can understand what a diagnosis is, to have them be part of the diagnosis, and to have somebody consider how do they want to refer to themselves. It is a somewhat different issue, and I think we have to be careful for medical records, for access to services. And I really have gotten myself in trouble with saying to somebody, you fit criteria for Aspergers, you fit for criteria for how people colloquially use Aspergers. You also meet criteria for autism, if we're being technical. What would you like to call yourself? And then having somebody come back and say, you know what, I can't get services with this. And then saying, all right, I'm going to have to write 2 reports, one with what you want to call yourself and one with what we're going to call you to get services. And that doesn't make anybody happy. But I think that's the world we live in. And I do think that nobody is saying that anybody has to call themselves anything. I think that's a separate issue. How a person defines themselves, how they think about themselves, and how they describe themselves to someone else is really quite a different issue than the diagnosis that determines, do we get health care reimbursed? And we think about all of that for, most of us don't go around with lists of our medical diagnoses when we're talking to our friends. We describe it in a particular way. So I don't think anyone, or at least I don't, want to change that or tell anybody what they have to say. Yeah,
Hi, I'm Seth Verk. I have Asperger's and I'm in the cognition department. So I have a very interesting perspective on all this. Thank you for your talk. Mm-hmm. I also have a legal background. I'm a lawyer. So I would like to discuss the legal ramifications of the diagnoses. For one, under New York State tort law, a person with Asperger's would be classified as an eggshell psyche plaintiff, which means that any emotional distress they feel from various events in their workplace would put them in a protected class legally. Mm-hmm. So I think it's very important to make the diagnosis as spectral as possible. So if someone isn't classified as Asperger's, they still have autistic tendencies, they still get something for the legal recourse. Also, I have to be honest, you keep calling it disorder, and I wish you would just call it a condition, because I'm not disordered. I have an IQ of 180. I graduated valedictorian of my high school. I have a law degree with honors. I have 2 science degrees from Berkeley, and I'm finishing my PhD in 3 years. So I am not disordered. Neither is Einstein or Tesla or Mozart. So if you could please change the word, it's highly offensive. I'd just like to fire some really quick comments. Being in the cognition department, I feel like the diagnoses don't address cognitive issues such as visuospatial attentional reasoning, cognitive overload, gestalt visual spatial processing, the ability to parse wholes into parts, and concrete thinking, which as an Asperger's person I could say is a hallmark of Asperger's. Additionally, I feel like your criterion does not take into account incisively the emotional complexity of reactions Asperger's people have to anxious situations, which should be dealt in much more incisively. And I feel on your committee, you should definitely have a few people who are experienced clinical psychologists who have Asperger's. Because I can tell you, neurotypical people often miss a lot of stuff that people like me don't.
Okay.
Thank you.
Hi.
Hi.
Thank you very much for your talk. I wanted to ask about the rationale for not including criteria regarding motor planning and or sort of the theory of mind, executive functioning, metacognition elements of autism. We know that they're related, and I wonder about why those weren't included.
The theory of mind is in there. So theory of mind or references to understanding other people's perspectives is listed as an example and would be people could pull from any example that relates to theory of mind. Motor planning is not in there and executive functioning are not in there. Not that we don't think they're very significant problems, but they're not universal in autism, at least as far as we know right now. And they're not unique to autism. So I think what we would suggest is that those would be other diagnoses. And again, you've got to remember this is a psychiatric manual. So it's not all diagnoses. So you could have a different motor planning diagnosis that comes from ICD-10. Executive functioning, is a problem for almost everybody with autism, or at least older kids. With little kids, it's harder to tell. But again, I think it's not at all specific to autism. There are many, many other people who have problems with executive function. So again, it's an additional thing, and it would be categorized just like intelligence or language disorder. It would be difficulties in executive planning. So you're not, or executive functioning, motor planning. So it's not at all that we're saying they're not important. It's just that we're saying that they aren't unique to autism and that you need to address them separately.
I'm sorry, we've run out of time for questions because we still have to be back from break by 11:15.
Okay.
Thank you so much.
Okay. Thank you.